Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, and this is a cardiology seminars brought to you from Houston, Texas. Our Triple N Media has more than 180 lectures on cardiology topics. You're welcome to watch each one of those, and we request you to please do subscribe to our YouTube channel. So let us begin with our feature presentation, which is heart failure device treatment. When do we need to think about a device like a pacemaker or an ICD in managing patients with heart failure? Heart failure is a progressive disease. Despite all our efforts, there is going to be changes in the heart function from time to time, either due to myocardial infarction or worsening valvular heart disease or infiltrative cardiomyopathies or non-ischemic cardiomyopathy. Nonetheless, the heart function may fluctuate. Hence, it is important to get an echocardiogram on a timely basis, or if there has been a change like a recent myocardial infarction, to get the accurate ejection fraction of the left ventricle. And based on that, we determine if these patients' conditions are worsening and if we need to do a device intervention. Of course, all these patients are going to be on maximum medical treatment, including ACE, ARNIs, beta blockers, and SGLT2 receptor blockers, diuretics, fluid restriction, aldactone, hydralazine, isosorbide, depending upon their condition. However, despite maximum medical treatment, if the left ventricular ejection fraction is less than 35%, and if the QRS duration is less than 130 milliseconds, if we have completely ruled out acute ischemia, I'm talking about reversible ischemia on maximum medical treatment or intervention, like even doing stents, if the ejection fraction persists below 35, and if it's an ischemic origin, it is a class 1 indication for placement of ICD. If we are dealing with a non-ischemic cardiomyopathy and the ejection fraction is less than 35% on maximum optimized medical treatment, we can consider ICD, which is a class 2A indication for non-ischemic cardiomyopathy. On the other hand, on the maximum medical treatment, if there is no inducible ischemia in patients with coronary artery disease, if their ejection fraction is greater than 35%, there is no indication for a device treatment in these patients. Now let's look at someone who has sinus rhythm, who has an ejection fraction of less than 35%. In addition to that, this patient may have conduction disturbances like left bundle branch block or prolonged QRS duration of greater than 130 milliseconds. And in these patients with significantly reduced left ventricular function and impaired right and left ventricular synchronization, we can consider CRT, that is cardiac resynchronization therapy. If the QRS is greater than 150 milliseconds, it's a class 1 indication for doing a dual chamber CRT so that we can activate both the right and the left ventricle simultaneously, improving the forward cardiac output and improve the symptoms and perhaps improve the quality of life. In fact, those patients who receive CRT are supposed to have 20% improvement in their symptoms and quality of life, and also improvement in the ejection fraction. If the QRS duration is between 130 and 149 milliseconds, it's a class 2A indication, assuming this patient has been on maximum medical treatment and is still having symptoms. So this is a quick overview of how to classify patients into different categories as who needs an ICD, who doesn't need any device to speak of, and who may benefit from CRT or cardiac resynchronization treatment. I hope this has been helpful to you. We have more than 180 lectures on cardiology topics on our Triple N Media YouTube channel. Please do watch them and please do subscribe to our YouTube channel. This cardiology seminars has been brought to you by Triple N Media. I am Dr. Nik Nikam and we will see you in the next video.